start?
Start.
Good afternoon, everyone. So I am presenting my research on the safety and efficacy of 0.01% atropine eye drop to control the progression of myopia in children between 5 to 15 years of age. As you all know, according to the global prevalence of myopia study, approximately 49.8% of the world population are going to become myopic by 2050. And as the level of myopia increases, it also leads to increased risk of retinal detachment, choroidal neovascularization, etc. So the aim of my study is to assess the safety and efficacy of 0.01% atropine eye drop. My primary objective is to assess the safety and tolerability, and my secondary objective is to assess the efficacy. It was a prospective case control study that was carried out in JPM Rotary Eye Hospital from May 2022 to April 2023. We included the children of age group 5 to 15 years with documented active myopia progression of at least minus 0.5 diopter with refractive error of spherical equivalent of minimum minus 2 diopter and with astigmatism of less than 1.5 diopter. Children with strabismus, amblyopia who are hypersensitive to atropine, they were excluded. 100 myopic children were recruited. Case group was taken as the right eye of the 100 myopic children and control group was taken as the left eye was taken as the control group. We administered 0.01% atropine solution to the case group and 0.5% CMC solution to the control group. Children were followed up at 4 months, 8 months and 12 months to measure the spherical equivalent K1, K2, axial length, ACD, lens thickness and retinochoroidal scleral thickness. Outcomes were measured in terms of spherical equivalent and axial length at 12 months. As you can see from this result, in case of case group, the progression is minus 0.15, whereas in case of control group, it is minus 0.62, and the p-value is less than 0.001. That is, it is clinically significant. Also, in axial length, the progression is 0.15, whereas in case of control group, it is 0.59, and the p-value is less than 0.007, so it is clinically significant. This is the time series plot depicting the progression of spherical equivalent and axial length over 1 year period. As you can see, in case of control group, it is increased from minus 4.81 to minus 5.43, but in case of case group, it is mostly constant. Also in axial length, in case of control group, it is increased, and in case of case group, it is constant. We also evaluated RCS, but it was clinically insignificant. No adverse reaction were found during the study period. So coming to discussion, pediatric myopia contributes to 22.9% of the world population. Recently, different studies like ATOM1, ATOM2, LAM studies, they have already shown that 0.01% atropine has a better treatment to side effect ratio. But they did not consider about the confounding factors. So the effect of confounding factors can be eliminated if one eye of the individual receives the treatment and another eye of the same individual can act as the control. Considering this existing paucity in the literature, our study aimed to study the myopia progression and axial length elongation in Indian population with one eye as the treatment and the fellow eye as the control to evaluate the efficacy of drug. In our study, the mean progression in axial length in the case group was 0.15 plus minus 1.04, and that of control group was 0.59 plus minus 0.65, and that was very similar to LAMP and ATOM2 studies. So I conclude that 0.01% atropine eye drop can be considered safe as well as effective to prevent the progression of myopia in age group of 5 to 15 years, as the results in our study show statistically significant difference. Thank you.
Uh, 0.01% atropine is now well known to control myopia.
Yes,
Whether you do it in as a contralateral eye study or you do it as an isolated study, there will be a proportion of eyes that will escape 0.01% atropine also, and there will be a proportion of eyes which will not progress, whether you use 0.01 atropine or you don't use. Okay. So there's some amount of doubt in the design of your study, but then the content is something that we have to ponder upon. Adding to that, you said there are a lot of confounding factors regarding the
Like outdoor
Okay.
activities they are doing, their near work, their screen exposure.
yes. So were these factors taken into account? Like,
Sir, that's why we took right eye as the case group and left eye as the control group, so that these kind of confounding factors can be eliminated.
okay.
So if you are succeeded in reducing the myopia in the right eye, the left eye, if you have kept in a control, then left eye will be in problem in future, isn't it?
Sir?
What I mean, because this is already an established fact that this atropine reduces the progress of myopia. And in your study, you have kept one eye for control and one eye you give carboxyminyl cellulose, and one eye you put that here. Okay, and the person. So 1 year after, 2 year after, when you see the patient, you will suffer from anisometropia. If this eye is controlled and this eye is not controlled, isn't it?
Sir, actually there were not much difference in right eye. In case of case group, there are also spherical equivalent was also increasing, but in case of left eye, that was the control group, spherical equivalent was increasing rapidly as compared to the case group.
That's why so 2 years after, she will suffer from anisometropia, isn't it?
That is to say, a contralateral eye
nice.
study is less ethical at this point when you have evidence that atropine 0.01% can reduce progression of myopia.
So other is
And-
progressing.
And given
So
that your
you'll-
study
you-
endpoints were safety and efficacy, safety is already well proven in the whole of the world population.
Sir, but still we are in the experiment phase and we have not established the data completely. So,
Chalo, just for the information of the house, there are new concentrations of atropine also being tried.
0.05%, 1%, but
Yeah,
sir, more side
newer
effect were there, and progression occurs after rebound effect occurs in 1% and 0.05%.